screening in all the patients. Means there may be different practices in Pakistan, there may be different practices elsewhere also.
So there is question number 13 me, that for any condition requiring hospital management, before admitting, whether they do the test. You are asking the same question, right?
Yeah. So because
actually, here some sequence has changed, so better you read them. Should we manage the which one?
Because there are three questions. They are almost interlinked with each other.
Yeah.
One is that should we manage the patient with cough, cold, fever, breathlessness in a non-COVID setup or send them directly? Secondly, do and don'ts in the newborn infant. And third, for any condition requiring hospital management before admitting, do you rule out COVID?
11, 12, and 13, right?
So basically, these three are interlinked. That what is the practice and what should be done. Fine. That is our target. That in a small setup, there should be a place where one should keep these patients. Even if they come out to be positive, later on they should be shifted after dealing with the emergency.
So Dhiren, all the 3-4 questions are coming to you only. So
okay,
because Dr. Robes asked me to ask it to you rather than him, because he doesn't want that question on clinical things. No?
Okay. So Bakul bhai, we are live on YouTube. So everyone is watching us, and we are also seeing this beautiful presentation. And you can see Dr. Russell Weiner that so quickly they have found about you, I hope. No. Amrita, you have not? Yes, here. Oh, this is okay. So we still have how much time to go? 5 minutes to go.
Dr. Naveen Thakkar is in Bahama. Dr. Dhiren Gupta is in India. Russell is in USA. Ella in Russia, and I am on moon.
Okay, and we are on YouTube live. So we'll start in 5 minutes till people join.
Yeah.
Oh, sorry. So there will be questions in chat, question answer, and also on our staff will post from YouTube to here. So I request all panelists to keep a watch. If we have time, we will be, address those questions also, or at least you can also interact by writing and they will take it back to YouTube. I request all panelists, you can also interact by answering the questions here, and we will post it on YouTube. We have 2 minutes to go. Dr. Julfi has joined.
Not yet, sir, not yet.
Okay.
Check, I'll check in that indeed.
So in our many of our IPA alumni has also joined. Dr. Uday Bodhankar, Dr. Swati was also supposed to join. We have SAPA founding president, Dr. C.P. Bansal. Yes, Amrita. Dr. Eldon, you can. Yeah, Dr. Julfi, welcome. And I will request all other panelists to mute yourself and when you are not speaking. Dr. Eldon, over to you. You are muted, Dr. Eldon, you are muted. Still you are, Amrita, can you unmute Dr. Eldon? Amrita? Yes, yes, sir.
Good morning. Shall I go ahead and start? Good.
Yes, sir, please.
Okay. Good morning, good afternoon, and good evening. I'm Dr. Errol Alden, President of the International Pediatric Association. The IPA is a 110-year-old global body representing and connecting pediatric professional societies all over the world. Our goals are to address the needs of children and ensure that accurate information is available to both the professionals and the public, so every child has access to the highest attainable standards of health, the opportunity for optimal growth and development, and the ability to fulfill their potential. The only proven effective method for the advancement of civilization is the care and education of our children. Today's webinar is the first in a series of regional seminars in sharing best practices from South Asia and the world in conjunction with the Indian Academy of Pediatrics. The Indian Academy of Pediatrics is an important member society of the IPA. From the very beginning, the Indian Academy has been actively involved in every aspect of IPA, including governance. I would like to name a few. Dr. N.S. Tiberali, Dr. Harish Chandra, Dr. R.S. Dial, Dr. Ramesh Potar, Dr. N.R. Bandari, Dr. U. Badankar, Dr. A. Gupta, Dr. Swati Bhav, Dr. Naveen Thakur, Dr. Rohit Agarwal, Dr. Pramod Jog, Dr. Dijant Shastri, and many such other leaders from the Indian Academy have played important roles in IPA activities and also gave their contributions in IPA governance. We hope to get similar contributions from future Indian Academy leaders. The IPA is excited about a future IPA Congress to be hosted in India in coming years. I would like to thank all of the speakers and panelists, Dr. Naveen Thakur and the IPA staff, Dr. Shraddha Utikar, Lindsay Sobin, Amaruta Vanderkar, Anita Tawari, and Deity Ravi for their excellent technical support. And now I'd like to introduce you to our co-sponsor for today's webinar, Dr. Bekal Jayant Parak. Dr. Parak is the National President of the Indian Pediatric Society, Secretary General of SAPA, and the CEO of Pediatrics at BPCH and Tertiary Care Center, Mumbai, India. Now here is Dr. Parak.
So thank you, Dr. Alden, for a nice introduction. And I'm very happy that IAP and IPA have joined hands together and doing this type of webinar for the first time, which I suppose we should do more frequently. And let's share our experiences and take our members into confidence. This was possible because of Dr. Naveen Thakur, the Executive Director of IPA, and also a past president of IAP 2007 and past president of APA in 2016-18. He has been Secretary of Child Health Foundation and he has been recognized as a as influencer about polio eradication by UNICEF, and is also on the board of Gavi and also on the board where they decide about pneumococcal infection and so on. His priorities are vaccines and infectious disease. So welcome, Dr. Naveen Thakur, sir.
Thank you so much, Bakul Bhai. And it's a real, for me, it's a double pleasure to join as a past president of Indian Academy of Pediatrics and also as executive director of IPA. As we have, the theme of this webinar is COVID-19 focus on pediatricians and children. We have talked about many other topics, but we definitely, our focus is also on most importantly on children. And if pediatricians are not well or they are suffering, we cannot take care of children. So this is a very specific theme of this, and we have good world-renowned experts. We have Dr. Julfikar Bhutta, who practically at present leading on every stream the evidence generation. We have Dr. Russell Weiner, we have Dr. Leila Namajova, and our own Dr. Dhiren Gupta, who has good experience in treating all the many of the COVID patients. We also have a SAPA office bearer here, Dr. Mumtaz Lakhani from Pakistan Pediatric Association, our friends from Bangladesh, and we also we have founding president of SAPA, Dr. C.P. Bansal, and others. So I will, this is my honor to introduce Dr. C.P. Bansal, the founding president of the SAPA, to tell something about the South Asia Pediatric Association. CP, over to you. Amrita, Dr. Bansal
is not there on the platform. He should be taken it, allowed to be inside.
Amrita, please.
Dr. C.P. Bansal and SAPA president should be taken. Yeah, on the.
Yeah, he is here.
Yeah.
Yes, Bansalji.
Thank you so much, sir. At the outset, let me profusely thank International Pediatric Association and Indian Academy of Pediatrics, especially Dr. Naveen sir, Dr. Eldon, and Dr. Bakul Bhai for inviting South Asia Pediatric Association in today's webinar. Thank you, sir, for recognizing the presence of South Asia Pediatric Association, a group of vibrant 7 countries and a home of nearly quarter of world's population. Sir, The SAPA took birth in 2013 in the presence of many leaders of International Pediatric Association. Two of them, very vibrant, are still present today in today's webinar, that is Professor Zulfikar Bhutta sir and Dr. Naveen sir in 2013, and that is Golden Jubilee Year of Indian Academy of Pediatrics. Friends, we, the member countries, might be independent geographically and politically, but our disease profiles and issues related to child mortality and morbidity remains the same. And therefore, we have to learn from each other's experience and work together for the betterment of child care in our member countries. Friends, the border conflicts and natural disasters and infectious diseases outbreaks periodically stall the progress of our already bad prognostic health indicators. I am sure all of you present here will agree that South Asia Pediatric Association now has a much bigger role to play than ever before during this dreaded pandemic. The COVID-19, friends, has redefined the meaning of security from traditional wars to the threat of viruses. We all have to make a new call to action, and let today's webinar be the first foundation stone in that. And let us make a call that the livelihoods are a topmost security today. Livelihoods are more topmost security today rather than the viruses, because we know now that it is not only the wars which kill millions of peoples, it is viruses which can kill millions of peoples. So it is most important in today's scenario. Considering various factors, it is expected in South Asia that even after COVID-19 pandemic is over, we will continue to witness a sustained race of wars as more important priority, sustained race of acquiring different arms and wars. And thus we may assume that guns will supersede the priority list among bread and butter. So friends, here comes the role of doctors, especially we all, to work together, to work cohesively, so that our leaders unitedly realize that the importance of prioritizing bread over guns, and that is the most important thing, and let it be a beginning of bringing and resetting the security priorities from wars to viruses. Thank you so much, friends. Long live SAPA, long live IAP, and long live International Pediatric Association. Now, let me have a sweet responsibility of inviting the current president of SAPA, Professor Ruhul Amin sir from Bangladesh. He has been president of Bangladesh Pediatric Association, and then he was president-elect and now the current president since last 3 years for South Asia Pediatric Association. He is not only a very good clinician, a very good medical pediatric teacher, but a very humble and gentleman, a very polite human being. Sir, over to Professor Zulfikar, sir. Professor Ruhul Amin, sir.
Thank you. Thank you. Are you listening to me?
Yes, we are listening. Please be very brief, Dr. Amin.
Yes. Dr. Eldon, Dr. Bokul, Dr. Naveen Thekar, and respected participants of SAPA member societies, presidents and secretaries, and learned dignitaries, and the participants of this webinar. So, since the inception of SAPA, in every national conferences of Bangladesh, Nepal, India, and also Sri Lanka, we could ensure a SAPA symposium exchanging our ideas and views and problems of our children. So that is a regular event in every conference of the national societies who are members of SAPA. And in future, in the near future, we are going to conduct a special conference and where we are going to chalk out they plan for next 5 years. So beyond COVID, the interest of the children of this region will be looked after very sincerely by SAPA leadership as well as the SAPA member societies. Let us remain united under the auspices of IPA and also APA, and SAPA remains an important cornerstone and for the safety, security, and the well-being of the children of South Asia region. Thank you very much.
Thank you, Bakul bhai, over to you.
Thank you. So let's start with our deliberations today. Let me tell you that COVID pandemic has disrupted our life totally and globally. Maybe in future we'll refer to this era as before Corona and after Corona rather than BC and AD. And probably the pandemic has challenged many tenets of our good medical practice and intensive care, like first, do no harm, to provide safe and evidence-based therapy, and in absence of such therapy, provide the best supportive care possible. But somehow the threshold for starting treatment, which is with unproven therapy, has changed, and we are directed by this novelty of disease to do this sort of unscientific thing. So let us lead the sort of discussion by asking first question to Dr. Leila. Dr. Leila, when to suspect COVID in a child, and what are the types of presentations in a child, and how do we confirm once we suspect?
First of all, good evening, good night, good morning, and good day for everybody, and thanks for inviting me. It's a great pleasure to salute you on behalf of 50,000 of Russian pediatricians and another 150,000 of European pediatricians. It's a great pleasure to be with you today, because we are all living on the same continent named Eurasia, so we are all together. COVID-19 in children is a very interesting issue because it has a multi-phase clinical features, as minimum 5. First is asymptomatic carriage, when we can find the virus SARS-CoV-2 in an absolutely well child. Second is a mild respiratory or diarrheal infections like course. Third is mild or moderate pneumonia. Fourth is severe distress syndrome, which is very rare in children, and you have to think about the tendency or the realized thrombosis in these children. And 5 is the most severe type, post-infectious multi-inflammatory syndrome, which is the analog of cytokine storm in adults. But I think we have to discuss this issue additionally. What everybody has to understand is that the specific receptor for SARS-CoV-2 ACE2 is situated on different cells of the body, on alveocytes, enterocytes, and many other cells, including brain. And the virus can affect, due to this reason, different systems and has different clinical mass. Not only respiratory symptoms can be observed, but also convulsions, strokes, and other signs. Some symptoms are often in children, like, for example, fever, dry cough, or sore throat, or diarrhea in every second patient. Some symptoms are seldom, for example, rhinorrhea, wheezing, headache, or myalgia. Concerning anosmia and loss of taste, which are very usual for adults, it's maybe from the first view more rare comparing with adults in children, but only because children do not actively present these complaints. But when we ask children actively and examine them objectively, we found that as minimum 2/3 of them had the significant loss of smell and taste even after 8 to 12 weeks after the after the end of the disease, negative test for SARS-CoV-2. Some of symptoms were absent only in child population, for example, so-called COVID fingers, and could be used as pathognomonic symptoms for COVID-19 in children, and new symptoms for children and adults were described last week, like skin rash, neurological conditions, and other. The diagnosis should be made for the child based on epidemiological anamnesis, patients with COVID-19 in his or her family, close contacts, etc. And as minimum as one of mentioned clinical signs. And last but not least, SARS-CoV-2 is not the usual respiratory pathogen. It damages CNS because it is neurotropic agent. And why the fatigue is so long afterwards? Because and why the cognitive functions are down and so on. We tested a lot of children who had the COVID-19 even in mild form, and among those, even 1/3 has the loss of cognitive functions, especially if they had unsolved problem with mental or neurological health before. PCR positive tests from nasopharyngeal or oropharyngeal swabs, EGM or IgA, but first of all, clinical signs, as well maybe with blood leukemia or leukopenia or lymphopenia, and doctor knowledge should be useful for the diagnostics. And such signs as the increased level of D-dimer, ferritin, HCA1, troponin, proBNP, transaminase, and others are very dangerous red flags.
So thank you, Dr. Leila. So probably you said that it varies from asymptomatic to symptomatic to maybe PIMS and maybe shock syndrome, and there are various presentations. And the gold standard to confirm the diagnosis, if there is a contact in the family or if there are suggestive symptoms, is by RT-PCR, and sometimes you can have corroborative evidence from your lymphopenias. Now, if you go to the perinatal period, if child is born to a COVID positive lady, what should be our time for cold clamping? In normal deliveries, usually we delay it by 60 seconds. So does it remain the same or there is any change?
There is no evidence about the vertical transmission, so it should be done, following this rule. Yeah.
Okay. Now, what are the recommendations for breastfeeding? Like when a child is born, usually we advise them to start breastfeeding as early as possible within first 1 hour. So what is your idea if there is a COVID positive mother, whether she should be breastfeeding the child?
This is a very essential issue, and on the website of IPA and SAPA, as well as other European associations, pediatric associations, we have the position paper of WHO that we made together with other pediatric associations of Europe. And this current guidance is that women with COVID-19 can breastfeed if they wish to do so, but they should take precaution, of course, including practicing respiratory hygiene during feeding, including wearing a mask covering mouth and nose, washing hands with soap and water with 20 seconds before and after touching the baby, and routinely cleaning and disinfecting surfaces that they have touched. Close contacts with the mother and early exclusively breastfeeding are both things that help babies thrive. So even if a mother has a COVID-19 positive, she is encouraged to touch and hold her baby, breastfeed safely with good respiratory hygiene, hold the baby skin to skin, and share a room with the child. And of course, if for example, the mother is too ill to breastfeed, we have to, in this case, she should receive support for safely giving her baby breast milk via other means, including expressing milk, relactation, or the use of donor human milk from certified milk banks if it's possible in your region. I don't know exactly if it's good advice for your region, but theoretically it should be done.
So thank you, Dr. Leila. So we have to continue breastfeeding the child even if you are COVID-19 positive, taking proper cough etiquettes and proper precautions like mask wearing and sanitization. And if mother is sick, then you can use express breastfeeding. So it's a good idea. And now suppose if child grows, then what is your idea? Like we are supposed to give all the vaccines, and primary vaccines should not be delayed in this COVID-19 era. But what if there is a COVID-19 positive child? Do you need to postpone the vaccination or do you continue doing the vaccination?
This is also a very essential question, and there is some statement of WHO, of CDC, and for example, in my country, we also have this special statement made by our pediatric community. We are absolutely agree that routine vaccination should be deferred for persons with suspected or confirmed COVID-19, regardless of symptoms, until criteria have been met for them to discontinue isolation. While mild illness is not itself a contraindication, to vaccination. But vaccination visits for these individuals should be postponed to avoid exposing healthcare professionals and personnel and other patients to the.
So if it's a COVID-19 positive child, then it's better to delay so as to prevent infection transmitting from him to the healthcare workers, and then maybe you can start continuing with the vaccine.
Yeah.
Thank you very much.
Yeah.
Dhiren, you want to add anything?
Yeah, just one point means that in utero transmission, vertical transmission do happen, though I agree it's very rare. It may be just 16 out of 1,000. And recently there was a report that it spread through the blood of the mother, and they could demonstrate not only in amniotic fluid but in the placenta also. So over the time, this virus is baffled everybody, so it's baffling us also. And regarding with the this new onset of disease, that is multi-inflammatory syndrome, because it happens in normally bigger kids, so we can continue the vaccination of the small kids because of the essential vaccination getting delayed. We have also seen that we have avoided the peak of the COVID-19 pandemic, but following that, we have started vaccinating small kids, especially less than 2 years old.
Thank you, Dhiren. Anything else you want to add, Dr. Leila?
It's important to know that in every community, after, in general, 2 months after the beginning of the epidemic, yes, we suspect to have some cases of multi-inflammatory syndrome. But after that, we will have the more normal situation. So it depends, of course, if you are in the beginning of the epidemic or you are in the, other part. So it depends from this. And of course, for us, it's very important to continue the usual routine vaccination, to be very, very careful with postponing in unnecessary cases. So it's you have to be attentive to a person who could have some problems with multi-inflammatory syndrome, but of course you have to continue the routine vaccination. And for this autumn time, we have to vaccinate also as much as possible people, including healthcare workers, against other possible pathogen as pneumo, as HIV, as flu, and others. Thank you.
So that's a good addition, that even the healthcare workers should be vaccinated if they are above the age of 50 years for influenza and pneumococcal vaccine. It gives cocooning effect also and protects themselves. Thank you very much. Now over to Dr. Naveen Bhai for further questioning.
Thank you, Bakul Bhai. A very good start. I request all the panelists to look into the chat box. Our staff is posting what questions are coming from the say YouTube, and you can respond here, and they will post back into the YouTube, because you can respond in writing, because we already have a lot many questions. We will try to answer as many as possible. Now coming to Dr. Julfikar Bhutta. Everyone knows, you as a master of evidence. And thank you so much for joining. We have a very fond memories of your lecture at Hyderabad and Calcutta. And I know you love this audience. So I will ask you 2-3 questions together, and you can, so I will combine this. So first is, what is the current state of evidence related to children about morbidity, mortality? We are hearing that many children are dying in Indonesia, other places they say it's not happening. We heard from Nepal today that, how many children are affected. So that's one thing. I think something already covered about vertical transmission, but if you want to add anything on that. And also, as our focus is on children and pediatricians, so what is the current state of evidence about COVID transmission? Every week there is something new comes up. Surface transmission previously was considered very important versus droplet and then aerosol. So why this is changing every week? What are the implications for clinicians? If we term this virus as an airborne spread, then how much distancing is required? Previously people said 3 feet, then 6 feet, and now we are hearing 9 feet. And so these are the few things, and any other evidence what you have gathered, till now. Over to you, Julfi.
All right, so I hope that I can remember the sequence and all. If you remind me if I miss. So firstly, absolutely thrilled to be speaking to this audience, and as a South Asian myself, I mean, I love the region and the fact that we are able to work together for something as
voice is a little low.
existentially
Loudly. Yeah.
Let me just see if I can.
Yeah.
You hear me now?
Yeah. Now it's okay.
Is that okay? All right. So I was saying I love speaking to audiences in South Asia because it's my own region, and it also happens to be a very important region with billions of people. So on COVID, it's important to remember that we are roughly in the 7th or 8th month of our knowledge of this infection. And therefore, whatever we say today has not yet stood the test of time. So the first caveat that I would put down is that we should always be in a learning mode and recognize that what we know about this virus is changing almost on a daily basis. And therefore, all evidence is interim. All guidelines on COVID that are being developed by WHO will be reviewed in 3 months, not even 6 or 12 months. So there is a process of updating and review. So we need to be very careful that whatever we say is not taken as the gospel truth. Second, this has also been a remarkable collaboration worldwide on data sharing, on information sharing, and also the web has made it possible for us to exchange views. So learning from people, which otherwise was only possible through printed medium or through journal articles, has been really fabulously enhanced by these webinars, by the possibility that most journals are now putting COVID articles as open access, and that we have preprints available for things that are under review. All of that has greatly enhanced our knowledge, and to some extent also our confusion around many things, because you have contradictory evidence for much. So we have put out from the IPA in collaboration with UNICEF a fairly recent compilation of what's known about children and COVID. It is in very easy to understand language, and I hope, Naveen, that you can circulate that to all people who are part of this webinar, because it has answers to many questions and perhaps can provide further background. So let me try and see what I can state. It is true that COVID-19 in children is a relatively milder disease than in young adults and older adults. In elderly, as you know, COVID is associated with quite severe consequences. About 76% overall of all deaths are in people above the age of 60, 65. And also comorbidities are more prevalent. In pediatric age population, there is no evidence that the risk of infection is lower. So they may have the same propensity to acquire the virus, but not necessarily the clinical infection. In fact, there is some evidence that actually the unit quantity of virus, the amount of virus in nasal swabs or pharyngeal swabs is actually higher than in other age groups, but it does not translate into greater infectivity or more severe disease. We typically see a J-shaped pattern of illness in children with very young infants and some newborns. The proportions of those with more severe illness, as indicated by hospitalizations, is greater than that in children above the age of 1, 2, 3, 4. And then you have a proportionately higher rate of complications, or let's say more severe illness, as you get towards adolescence. Now, it is possible that in the younger age group, our thresholds for hospitalizing infants and newborns with COVID positive infections is a bit lower. So being in hospital is not necessarily a measure of severity, but that's the only thing that we have. But overall case fatality rates in children are generally lower in most series than 0.5%, which is much lower than others. And the few case fatalities that we have had in children have generally been accompanied by comorbidities. And that's general for COVID infections. Now, our review of multi-inflammatory syndrome, or Kawasaki-like illness, will be published on August 17th in the Lancet Infectious Diseases. I would urge everybody to see it, because it's one of the most extensive up-to-date reviews on the subject, which supplants things that have been published in New England Journal of Medicine and JAMA. So I'm going to try and summarize what we know about MISC, and the co-authors on that review, led by my team, are Professor Mike Levine and others who have actually worked on this discipline. So firstly, it is a relatively rare disorder, and one should not be scared of this as an inevitable consequence of COVID exposure. We still don't quite know why some children will get it and others don't. There are similarities to toxic shock syndrome, Kawasaki disease, and Kawasaki disease-like shock syndrome. But there, the similarities disappear. So it does appear to be a unique syndrome that we are seeing, in which it is not clear that this is only a cytokine-related phenomenon. There could very well be things that pertain to T cell dysfunction and also, of course, a response in terms of developing autoantibodies. But what we know is that despite all the difficulty, the treatment strategies that have generally worked in these children with inotropic support, cardiac support, the use of IV immunoglobulins and treatment that we have standard for Kawasaki does work. And at this stage, there is no reason for us to suspect that case fatality rates in this would be significantly higher than what we have for Kawasaki disease. It's a rare disorder. We tend to see it, as Leila was saying, in a few weeks after initial exposure of a population to COVID-19. And we don't see a persistent pattern of high prevalence of this. There is a case series just published by Professor Masood Sadiq from Lahore, which is in our region, on Kawasaki-like syndrome in children from the Institute of Child Health. I just come out in Lancet Child and Adolescent Health and Correspondence. So you can look at some of those in terms of cardiac and other manifestations of this disorder. So I'm not going to talk about this disorder anymore because it's rare, and I don't think ordinary pediatricians should be too concerned about it. There is always this worry if we send our children to school, whether they get it or not. I don't think that's necessarily the case. But you should be aware of it. And as I said, the review will come out on the 17th of August in Lancet Infectious Disease that you should have access to. Now, you also asked about, Naveen, if I recall, the risks in pregnancy and perinatal period.
Yes.
So we have a systematic review that's gone for peer review. So here is the interesting thing. Overall, in populations where we have had COVID exposure and lockdowns or what have you, actually rates of premature labor and premature births have gone down. This is a very interesting phenomenon. Overall, it looks like population prevalence of prematurity has gone down in this time period. And that may be related to things like maternal rest, the fact that exposure is limited, etc. But if you look at the evidence of pregnancies where there has been COVID exposure of mothers, and particularly those where there has been more severe disease as manifested by hospitalization, need for oxygen, etc., adverse outcomes in pregnancy are higher. So there is an increased risk of adverse pregnancy outcome with COVID infections. There is not an insubstantial, but there is a small risk of increased maternal mortality also. The last question you had asked, Naveen, was around mode of transmission, aerosol, what is the recommendation, etc. I think it's very clear now that we have asymptomatic people who not only transmit, but can transmit by aerosol. And that's one of the reasons why when we use masks, you have to be very careful with the type of mask that you're using and also the reuse of masks. So I think masks should be absolutely a must for practitioners and also for people who are going to be in close proximity. I don't think there is any evidence at this stage that the recommendation for a 6 foot or 2 meter distancing is inappropriate. I think that's what we should probably have. Reducing that down to 1 meter or increasing that to 3 meters seems pretty arbitrary at this stage. But I would very strongly endorse and recommend the use of masks universally, which should be changed, which should not be very flimsy masks, and they should be masks that have the capability of preventing both droplet and aerosolized infections. Over.
Yeah, so thank you, Dr. Zulfi. You said that initially we used to believe that children are most of the time asymptomatic and they have less virus load. But as you very clearly said that they can be a high transmitter and we should not lower our guard. So keeping this in mind, I'll ask next question to Dr. Dhiren Gupta that should we be managing the patients with cough, cold and fever or breathlessness with SARI or ILI in a non-COVID setup or send them to a directly to a COVID setup?
Sir, over the time, means so just one point on the over Dr. Zulfi regarding the spread of infection. I think whether it's aerosol or droplet, it all depends on the environment. Means other than the mask, you have to take care of your indoor environment. I think that is if indoor environment is completely secluded, then this virus spreads very easily and you get this infection very easily. So need to have good environmental control. Now, one more point regarding that acquiring pediatric, it used to be said that they acquire infection 54% less than the adult. It may be that over the time they were all asymptomatic. So actually, we don't know whether they acquire less or no, but they can spread the infection. The point you have asked that when we are in pandemic, when we are at peak, actually there is no hospital which we can call it a non-COVID or COVID one. And secondly, whether it's a small nursing home, whether it's a big hospital, you have to have an intermediate area where you need to give them adequate care, especially during emergency. You can't send them to any hospital, any COVID so-called COVID hospital without giving them emergency. If you prove it's COVID, like you do an antigen test, you get a result within a half an hour or 45 minutes. Or now we have got PCR, rapid PCR test, and only then you can decide. So we need to treat not only a patient who is coming with any other emergency, what Laila said that they can present not only with SARI, they can present with any problem, any non-respiratory problem also. But we have to take care of these patients in emergency at any cost.
So, Dr. Dhiren, that brings us to that every most of the time, 80% of the time, our patients are either having fever or cough and cold, and we can't keep sending them away. Otherwise, what you will do in your own practice. So, you wherever there is history of strong contact in the family or there is strong suspicion, you may put it in a area where you can give emergency management and investigate. And once it is proven as COVID-19, then you take further steps. Now, suppose if we admit this patient in a small nursing home, so 5 to 20 bedded nursing home, and along with child, there are attendants also like parent or somebody else. So should they be also screened when they are allowed to be with the child, or is
Sir, yeah. Sir, it's not possible to screen each and every attendant. In India, especially in Southeast, we know that how many attendants are there with every patient. They change every minute, every day. Now, the best thing is that ask them to wear mask if they are asymptomatic. So you should not allow a symptomatic, you can say, child attendant to be with the child. And even if they are mildly symptomatic, if you put up a mask, the beauty of the mask is, as the previous speaker said rightly, whether it's an N95 or simple surgical mask, it is good enough to prevent the outgoing infection, the infection which gets spread into the environment. And though it may be N95 to prevent the small particle to go in for the healthcare worker. So best thing is that have an environmental changes and ask each and every person, whether it's a healthcare worker or any person who is accompanying the patient, should wear that mask, and that should be sufficient to prevent the outgoing spread.
so I think proper mask and sanitizers will help you in avoiding this particular disease infecting you yourself. And as you rightly said, the spacing should be very good. It should not be a very enclosed place with AC and too many people sitting nearby. So I think with all these precautions, you can avoid cross infection and treat these patients till they are better.
Just
Now,
last point regarding AC, air condition has to be a part of HVAC, but recirculation should be prevented. We cannot switch the heating or air conditioning systems.
okay. So regarding AC, I think also it's been told that it can cause turbulence. So ideally in your consulting room, you should have your exhaust fan on or windows open, or it should be an open space for air and ventilation. Is it right? Or you can,
Yeah.
because when you wear PPE kit totally, it's very hot. And without AC, it is very difficult to continue seeing the patients for a very long time. So maybe this exhaust fan and other designing of the consulting room may help you.
Yeah, sure, sir. That is very important, and that prevents heat stress also. Otherwise, thermal stress can lead to a lot of infection, not only in ICU, simple ward, and simple emergency. That is must.
My now next question is to Dr. Rob. For any condition requiring hospital management, before admitting mother or a child in the hospital, is it necessary to rule out COVID-19? Dr. Bob Ross?
No, Dr. Russell Weiner is there, Bakul Bhai.
Dr. Russell Weiner, okay, sorry. Dr. Russell Weiner, please, yeah. Sorry, yeah.
Sorry, thank you. Thank you. So welcome from the European Academy of Pediatrics. I'm standing in for Rob Ross Russell, who wasn't able to be here. Screening for COVID-19 is essential. If we have sufficient screening capacity for all admissions to hospitals, certainly in countries that have sufficient screening capacity, we should be testing children and young people and parents if they stay in with them where possible. Many countries have systems that discriminate against children, that don't allow the testing of young children, and this is very problematic for care. I think there are differences between the admission of acute patients and elective patients. In the UK, we are testing all elective surgery patients at time of admission, but are not requiring them, for example, to be tested 2 weeks beforehand or to quarantine 2 weeks beforehand. Obviously, for acute patients, you need to test at the time, and I think the discussion happened before about needing to treat all potentially infectious patients as potentially having COVID, depending on symptoms.
So I gather that if there is an emergency, you have to save the child first and treat them in a separate room till you get the test report. Or otherwise, if there is a planned surgery or planned admission, then of course you can get the RT-PCR done, and then depending on the positivity or negativity, you can admit or child or a mother in the hospital. Thank you very much, Dr. Russell Weiner. Now, Dr. Naveen, will you like to ask some question? Yeah.
Yeah. So Dr. Russell Weiner is current president of RCPCH, and we are very happy to have you here, Russell. And Rob Russell, who was supposed to join, met with, and his car was broken, and thanks God they are safe. But Dr. Weiner just, I think, got few minutes to join this. Russell, as our second, as we said, our focus is today on children and pediatricians and our colleagues. Daily, we start the day at present in India with the news that we have lost some colleagues, and also pediatrician as well as healthcare professional, and it is, it's really increasing. And I would like to have your experience from Europe, because Europe started quite early and you have also lost many colleagues. So my colleagues and the audience wants to know about your experience about pediatrician, whether they have more risk. There are studies coming out that children have more viral load and all that, and how they can protect themselves, and whether they should worry from asymptomatic child, or when the child is crying, sneezing, vomiting, or soiled cloths. Does a crying child have more chance of infecting the doctor? What and how to examine a child to avoid yourself getting infected? Then definitely when it comes to protection, we come to PPE, and we also get maybe misinformation or correct, whether the PPE are 100% protective. Recently, we got a study that whatever you do, still you have 3 times more chances than the general population. That's really worrisome. What type of PPE should be used to protect ourselves in different situations? Healthcare workers also seem to get exhausted of donning PPE. They try to find the way of comfort, compromising safety. So how do we save our colleagues? How do we advise? Because the evidence coming out, whatever it may, but it's a very conflicting. Daily there is something new. So with your experience in Europe, and also I know you have also published a lot. So what is your experience? How we can save our colleagues in healthcare professional and particularly pediatrician? Thank you.
Thank you. Thank you. I mean, it's a sad fact that this pandemic has claimed the lives of many healthcare workers, doctors, nurses, and others around the world. Our experience from Europe and the UK is a very mixed one. I think Zulfi is absolutely right. What we know today will not be what we know in 3 or 4 months. I think we need to be careful, however. We need to be careful in multiple ways. We need to be careful about the assumption that children, in a sense, are less affected. And we need to make sure that our colleagues protect ourselves. We need to be careful about studies that might show that children have higher viral loads, because many of those studies are quite flawed. So there's a number of studies coming out showing different things. What we have found in Europe actually is that the most intensive healthcare workers, doctors and nurses in the most intensive settings, such as intensive care units, where they're doing aerosol generating procedures routinely on highly infectious adults and children, they're actually the best at protecting themselves because good PPE wearing is routine. They stick with it. There is a culture of wearing PPE properly, and actually they have a very, very low rate of severe illness or death amongst those who work in intensive care. What we have found across Europe and in many countries and in the UK is that it is healthcare workers who are not at the most intensive level, but who are often doing primary care or doing something close to this, who make assumptions that they don't need to protect themselves. It is these groups that are more at risk. And often, sadly, it is our nurses and other workers in hospitals who are much greater risk than doctors. And some of this is about knowledge. We have lost pediatricians in the UK, and I think this is true of many countries in Europe, very, very sadly. One of the things that's important to say on this call, I think, is many of the healthcare workers, not just pediatricians, but others who have died in Britain have been from have been doctors and nurses who have come to the UK to work, many of them from South Asia, from countries in India. And the sacrifice of those colleagues is hugely felt by the profession in the UK and more internationally. Again, that may be about where they work in the system rather than their ethnic background or what they do. In terms of children versus adults, there is some interesting data on that. I know of only one study that compares healthcare workers in a pediatric setting with an adult setting, an interesting study from the Necker Children's Hospital in Paris. And they actually found that healthcare workers, doctors and nurses in that hospital had a lower prevalence of infection with SARS-CoV-2 than in a very large adult hospital next door. And it's very unclear why that was. The study wasn't able to show the differential in risk. It could be that pediatricians in general are used to dealing with infectious diseases. Many of the children who come to our hospitals, to our clinics, are infectious, they have fevers. We are used to dealing with this. We are used to body secretions, dirty nappies, babies that cry on you, spit on you. This is the life of a pediatrician, and much less for an adult. It may be that. It may be something to do with transmission from children. That's very unclear. What is clear is that pediatricians need to have the highest standards of protecting themselves as much as for adults. The great danger is that children are often asymptomatic. We predict that as winter comes in the Northern Hemisphere, we will have even more problems being able to work out which children with fevers may have COVID-19, which have RSV, which have a range of other simple winter viruses. So this will be presenting a major issue for healthcare workers, I think, across not just Europe, but across the world. In terms of types of PPE, what is recommended in the UK is that all clinical interactions with a patient, the clinician should wear a simple mask and a simple apron and gloves. And many countries are different, but taking very simple precautions for every single patient, regardless of whether they are infectious or not, but then having, if a patient is likely to be infectious, a patient particularly with a fever, or particularly with some other more COVID-like symptoms. And this is where it's very difficult in children because the symptoms are different to adults, but they should be using much more strict PPE, such as more protective masks, potentially visors and gowns. That is not always possible in all situations, but that is what I think we should be encouraging our colleagues to do. Thank you.
Kulfi, do you have any comment on that or any?
Yeah, I think Russell is right. One important thing to underscore is if you look at certainly in South Asia, and I've been very grateful, Naveen, that you did send me some files on physician deaths in India and Bangladesh, and I've looked at the data for Pakistan. It is interesting as to how many of the people who have been severely infected and those who have died have been people who have not been on the front line, not necessarily frontline ICU workers or emergency workers. They have been actually people who are incidentally infected as part of their practice. That's one of the reasons why you see ENT specialists, you see pediatricians in that mix of people who are not necessarily frontline workers. And I think there's a lesson in that, that perhaps the care in terms of avoiding exposure and mitigation measures through proper use of PPE, hand washing, sanitization, and principally not undertaking risky, maneuvers. They ought to be frontline and center. One of the earliest, remember, victims of COVID-19 was an ophthalmologist. So I think it is very important that we don't let a guard down. And particularly people at risk are those who are in primary care settings, seeing people all the time without necessarily thinking that they are at risk because they're not handling them in emergency settings or working in ICU. So it's important to at least make sure you have the right type of mask and that you have a mask that fits, and also that you have precautions in terms of what you touch, and particularly ensuring that you are appropriately taking measures when you do risky procedures like ENT examinations or coming close to patients.
Can I come back in? Zulfi, I entirely agree. And the same thing that we've seen in Britain and across Europe. It's not necessarily the most acute people, it's people in the middle. And there is a lot of transmission in hospitals in some settings. And one of the problems is hospitals are places where there is quite a bit of potential infection. Clinicians, pediatricians protect themselves when they see patients. And when they go to their staff room or they see mixed with other healthcare workers, they relax, they take off their masks, and infection happens. And so hospital staff rooms are risky places.
I think the analogy that we will get into, Naveen, if I may just take this line of thinking forward, and Russell's one of the world's experts guiding us right now, is really how does this translate into practice in other areas where there are lots of children, schools. And the lessons that we have from some of these mitigation strategies are extremely important for protecting children in schools, right way, not overdoing it also, but also protecting teachers and ensuring that where children are going to be in contact with family members in mixed family structures where there are elderly or potentially people at risk, that some of the basic protection measures that we need, like hand sanitization, use of face masks and distancing, not congesting classes too much, those are put in place. I am very keen, I'm exploring with a couple of governments right now, that in areas where the weather conditions permit, that you could actually have open air classes rather than lump a lot of children in a very small room together with poor ventilation and thereby increase the risk of transmission. I mean, I grew up and went to a public education system where we had open air classes. We sat outside in the sunshine or in the garden and had classes there. Those are the kind of things that we can do as innovations in low income settings and in areas where we cannot clearly build new schools. In the US plans, there are plans to build new schools. Even they cannot afford it. But we cannot do that necessarily. And I think moving to a shift system of classes, moving to a protection, and moving to some innovations like this also have implications for the way we organize our outpatient clinics in hospitals. I mean, that's also another area where we can reduce risk of transmission.
Thank you. Leila, you would like to say something? You raise your hand. Or?
Few words. I totally agree with Russell and with Zulfi, and we have the same experience. The people who was working in red zone hospitals or in red zone in the hospital, within the hospital, had less cases of transmission than the people who were working in the normal green zone, so who are not so aware about this. And the second point about glasses, there is more and more evidence that SARS-CoV-2 can go through optic nerve, and so we have to protect our eyes as well as nose and mouth. And I think that for many of pediatricians, it's very important knowledge to protect their eyes. And the last point is about hydration that was mentioned before. In the situation with COVID patients, we have to especially be very accurate with hydration and to use appropriate volume of liquids, which is in this situation more dangerous to give too much than less. And the last point about nebulizers, who are still very popular in different facilities, and in this COVID time we can't use not only this system for air systems, but also nebulizers, just only personal aerosols to avoid this transmission of viruses. Thank you.
Thank you, Leila. I think we have already 1 hour is over, and we have to also go to SAPA office bearer. But before that, very quickly, Dhiren, you have, in India now we have seen there are a lot of, when we started, the treatment line was different, and now there are a lot of learning, and the mortality has also gone down. So, but Bakul Bhai will ask that, but I want to just start by, some question like clinical early recognition of problem, roll up of pulse oximeter, respiratory rate, red flags, in very brief, and or you can refer to some resources, how to monitor progress, because, every pediatrician, every doctor has still the same question. What should I watch when I should go to the hospital? When that's what is meaning of cytokine storm, what is happy or silent hypoxia. But I know this is all cannot be covered. But if you can start, and then Bakul Bhai will follow up with the investigation and treatment. But we have to, wind up this section within 10 minutes.
Okay, sir. Just give me 2 minutes because I totally agree. This is a very important part. And I'll take 1 minute to make everybody understand the pathophysiology, because that will make us to understand how the treatment follows. So all this, you can say, knowledge has come from the adult practice. And we all know that it starts with a viral phase. So first 5 to 7 days is a mainly viremia. And take my word, viremia rarely kills anybody except the immunocompromised, and especially severely immunocompromised. This virus has got propensity that it enters the epithelial cell. We all know that it enters in the lung and it enters the epithelial cells, but also simultaneously it enters the macrophages. And unfortunately, we call it an abortive infection because it enters, it kills the macrophages, it leads to cytokine, you can say, leak, but it doesn't propagate there. So we call it an abortive infection. That is a characteristic of this infection. So what happens during that 7 days of, you can say, a viremia phase, some patient can still have a little bit, you can say, cytokine release that time, fine. Now, thereafter, the problem starts. So most of the patient do settle, say 95% out of all, but if patient is having comorbidity or be greater than around 50, 60-year-old, the period of cytokine starts. We call it inflammatory stage. This inflammatory stage, the shift from a viremia simple phase to the complicated pro-cytokine or pro-inflammatory stage is very important. Since it is primarily a sort of HLH of the lung, so in adult, primarily the disease, complicated disease manifests in form of respiratory symptoms. So it can be increase in respiratory rate or saturation drop. Now the drop in saturation, we call it silent hypoxemia. What happens? The compliance is not that low, as well as your carotid body get affected by this virus. So patient may present with low saturation or high respiratory rate. These are the two signs we should watch for. Many adults, by their compensation, what they do, they try to compensate the drop in the saturation, which we normally call it less than 94 or equal to saturation 94, or rate, respiratory rate more than 24. These are two, you can say, red flag sign. But more important is that to catch it early. How we can do? Ask him to have a 6-minute walk. If you find a saturation drop more than 4, suppose I am having 98, but it drops to 4 after a walk of 6 minutes, after say 5-6 days of the viremia phase, this is an important time. This is an important sign. It means, even nutshell, it's a reappearance of fever after 5-7 days, appearance of breathlessness, high grade fever, especially more than 102 with rigors. Drop in the oxygen saturation after 6-minute walk is very important. One point I want to make: if you find any patient in emergency, despite that oxygen saturation is low, you apply oxygen. If you find that oxygen saturation is still less than 90%, these are the very high risk patient. In these patients, as compared to any other patient who is desaturating, but is able to maintain oxygenation by giving oxygen, say less than 5 liters per minute, these patients do much better on simple steroid. The patient who doesn't do well on simple oxygen in emergency, when we have got first contact, these patients have got very high risk, and it is said that each increase in saturation by 1, there is a mortality decrease by 8%. So these are the patients who may require drugs like tocilizumab or plasma therapy. So in nutshell, we need to look at the respiratory rate and the saturation. That gives an idea this patient is likely to deteriorate in given day.
So Dr. Dhiren, when COVID-19 like symptoms appear in a adult or in an adolescent and is very mild symptomatic or slight fever but nothing else, should he be taking drugs like HCQ, ivermectin, doxycycline, azithromycin, or they are useless?
Sir, they are actually useless, and I feel that they deviate our, you can say, focus towards the actual treatment. That is, actual treatment is whenever there is a cytokine storm sort of happening, which is after 5 to 7 days, that is a hyperimmune phase. Then you need actual steroid, and every 6-hourly delay in institution steroid actually leads to a lot of problem. Now we are viewing a lot of pulmonary fibrosis. So all this treatment probably are unproven, and again the debatable thing, but definitely they are not that useful as focusing on this period, that is important period of say after 5 to 7 days, the immune phase which is happening in the patients.
Okay, so probably in a mild disease, I think it's better to take supportive care, proper rest, and try to self-monitor yourself, looking at your pulse oximeter walking test, and maybe rise of temperature of day 6 is occurring or not. And suppose if there is, you are entering into a moderate phase where your oxygen is going down and you require admission, should we start antivirals immediately? And if yes, then whether favipiravir or remdesivir?
Sir, actually, the antiviral drug is needed only first 12 days. As I told you, including viremia phase. Only in the high-risk patient, they have given, they seems to be useful. Otherwise, in most of the patients, you don't need antiviral therapy. You just give steroids to suppress the storm. And say out of 100 patients, what I have seen, 95% patients do settle with simple steroids. Antiviral drugs has to be given in highest of the risk, like severe comorbidity, especially obesity and diabetic patients, if they come within 12 days, or if you are giving drugs like tocilizumab, we know that they immunoparalyze the whole system. then the role of these two antiviral, we call it remdesivir or favipiravir. Regarding favipiravir, though it reduces the clearance, but its role is in very early stage when patient is of very mild or moving towards moderate. But the drug which can help us is remdesivir, and many of the patient comes late, say 14th to 15th day with late cytokine storm, then the use of this drug is again doubtful. So there is a very narrow window where we can use this drug remdesivir.
So I understand therapy will not have much role unless it's a very mild disease and you have to take so many tablets at a time. But if you are in a moderate disease and you have a comorbid condition or high risk condition, the remdesivir may help you. And steroid is the main drug which you should start when there is moderate involvement. And in amongst the steroids, whether you will prefer methylprednisolone or dexamethasone.
Sir, any of the drug means though there is interaction between DEXA and remdesivir, but that interaction is not that much. In fact, there is an interaction between chloroquine and remdesivir. Again, there was a warning from FDA, but that is not very clinically significant. One point I want to make, I am talking about steroid, but if you land up in giving steroid very early without this cytokine, then again it increases the mortality by 3 times. That is the recent data. And one point I could make out that there's one study which says that if you find CRP more than 20 or more than that, means if it is rising, then it's a benefit. Then it's a other than clinical guide. It gives you a guide. Okay, you can give steroid. But those patients whose CRP was less than 10, you land up in giving steroids, then mortality increased to 3 to 5 times. So we need to examine them. We need to, you can say, follow them clinically with respiratory distress, oxygenation, with this cytokine marker, and CRP is the most important marker out of all, other than D-dimer.
So see, once you start oxygen, patient is not improving oxygenation wise, and your oxygen requirement is increasing, and your cytokine storm, that is CRP, which is a surrogate marker of IL-6, is rising maybe 5 to 7 times than the normal value, then your steroids should be started immediately. Now, once you have started the steroids, you are given oxygen, and now oxygen requirement is increasing more than 10 liters. You have started proning the patient. As we know that proning helps in getting oxygenation better, but still patient is not improving, then probably you'll go for HFNO rather than your mechanical ventilation. Now, still if child is or patient is not improving, what is the role of tocilizumab? Is it helpful? Because the recent report says that sometimes it may cause more harm rather than help. So what is your idea? What is the narrow window when it should be given, and how much dose should be given? Should be given only 1 dose and stop, or can we repeat the 2nd dose or 3rd dose, because it is supposed to suppress your immunity and lead to superheated infection?
Okay, so first of all, let's see the benefit. Those patients who are in cytokine storm, as I told you, most of them do settle with steroids. Means you have to have patience of at least 36 to 48 hours. Don't jump onto these biologics. And as you rightly told, these biologic immunoparalyzed, and they increases 1 dose of tocilizumab can increase the infection rate by 20 to 25%. And secondly, one more important point is that if you suppress interleukin 6, God doesn't give you anything free. If it is giving you interleukin 6, it has to be some meaning. So this interleukin 6 at times prevent fibrosis also, lung fibrosis, and it helps in, rebuilding the lungs and various other organs. So we should not try to suppress each and everything unless it is, it is troubling the patient or child. So we should be very cautious regarding anti-interleukin 6. Just 2-3 points. It can lead to increase in the infection rate, especially if you land up in giving 2 doses. So be cautious in giving 1 dose. There are clear-cut indications. Clinically, patient is deteriorating, oxygen level is going down, as well as markers of inflammations are very high. Very high means at least 3 to 6 times the normal. Do not try to chase just one marker. If you find, okay, there's a CRP, you start chasing just one marker, you start chasing ferritin, you start chasing LDH. That is not right. It has to be clinical plus markers. Both has to be taken simultaneously. If you are confused here, definitely you can take help of imaging. Probably next question is going to on the imaging. So in this disease, I've done mistakes few months back. By learning, I've learned that patient has to be followed clinically as well as markers plus radiologically. These three things has to be matched, and we need to move forward. While tapering the steroids, again the same thing. You cannot just rely on your clinical sense. If you try to stop them, then patient can crash and can land up in the major problem. So regarding tocilizumab, give it only if it is required. As I told you, indications are very clear. You can give in a progressive disease if not controlled by steroid or little bit high dose of steroid. You start with 40 milligram once a day. You increase the dose of methylprednisolone. You can choose either. You can either increase the dose of steroid, whether it's a methylprednisolone or your DEXA. And if disease is not settling, if other indicators are also giving you an idea, this is only cytokine storm, then the role of plasma therapy and this type of therapy is there. And one more point, that at times in immunocompromised patient, it may not be just cytokine storm, it is the infiltration of the lung. It is actually primarily pneumonia caused by this disease. This virus is actually the reason. And if you give them unnecessary tocilizumab, your patient is going to land up in problem. So be cautious when you're using these biologics.
So I summarize that you will start with oxygen when the silent hypoxia is there and you get admitted. If your oxygen requirement goes on increasing, you start steroids. And once you start steroids and child is not improving and there is a rise in CRP and other markers, you may give plasma therapy when virus is active. Otherwise, it may not be helpful. But then you can decide about tocilizumab if everything else is failing and our oxygen requirement is going up and up. And one dose of tocilizumab is more than enough. You give second dose, the chances of super infections have increased by 50%. And your plasma therapy, if given late, may not be very useful. What about cytosob and plasmapheresis? Is there any role if they don't respond to your tocilizumab and other therapy?
Sir, I've seen around 6 patients giving cytosorb therapy. Cytosorb is you can say, an absorbent which absorbs these cytokines, and you fit in your CRRT machines. The problem with this is that it also absorbs the anti-inflammatory markers. So as I told you, it's not only, interleukin 6, but there are many chains, interleukin 1, CX, CS10. There are many other cytokines which also get cleared up. And these cytokines were actually helpful to those patients. So that's why it's just helping 1 or out of 100 or 150 patients. And again, indication is not very clear. As per the, you can say, FDA, the indication is refractory hypoxemia, PF ratio less than 150. But people have tried to use in the mild to moderate. When mild is shifting towards moderate, and you have consumed all the therapies, especially prone ventilation, at this time, if you start using, it may be of benefit. But again, only one therapy like cytosorb use is not found to be very beneficial. It's a very costly. One filter costs you 1 lakh. It's quite expensive. Secondly, your plasma exchange. Plasma exchange seems to be better than your cytosorb. And it has been found that if it is linked with, you can say, TOF, that is your low platelet, and if you find that all cytokines are high, and you will need 5 plasma exchange to be helpful. So this may be have edge over your cytosorb.
Yeah, so thank you very much. And regarding injection Lasix, which they give to keep the lungs dry and keep urea at 60, and insulin they give to keep the sugar under control, because there can be hyperglycemia because of use of steroids, and that may help in controlling the disease. I think now over to Dr. Naveen Thakkar sir for a further question.
Thank you, Dhiren. Thanks for all your input. I hope you can share your journal article in chat box and YouTube, or you put in chat box, they will share if you don't mind. Dr. Julfi, Dr. Russell, do you have any comment, anything to add from UK, Julfi, around the world?
No, I mean, what I will say, Russell can chime in, is that the role of pediatricians in this particular disorder is critical, not only for quality of care and improved practice, but also in keeping their eyes and ears open. So I am alarmed by a few reports that I have read about long-term consequences or long-term impact of so-called even milder pediatric infections with COVID. And more worryingly, there are two reports which are as yet in the non-peer-reviewed literature of findings in so-called asymptomatics. So I think we are all learning in this. There will be a fabulous role down the road if we find an effective vaccine of pediatricians helping scale this up. So I really welcome the collaboration, and pediatric associations, whether they are regional, national, or global, have a tremendous responsibility of being not only purveyors of good information, good practice, but also research. So I would make a plug for learning and multi-collaborative, pooling data information, putting case series together. I've done 3 systematic reviews on COVID over the last 3 months, and all are hampered by the fact that we're looking at separate reports without the opportunity of pooling data together. So this is a call for people to come together as consortia, to look at individual data, to look at details, to improve our understanding of what is really quite a challenging disorder. Thank you.
Thank you, Julfi, and stay on. We have, office bearer.
Just 1 minute, can I take?
Yeah, please go ahead.
Because Dr. Zulfi is there, I want to take advantage of that. What I could search, past 15 days, I was really troubled by this multi-inflammatory syndrome. Why it is not affecting lungs? Why IVIG is the first modality of treatment, whether it's not used in adult? So what I could find is that there is a moiety between S1 and S2 that acting like a super antigen. And it is as a super antigen that is leading to this type of toxic shock syndrome. So actually MIS-C is a toxic shock syndrome with Kawasaki-like features. So original Kawasaki is nothing to do with this. So it is like a super antigen which is giving you a toxic shock syndrome, and it affects like CD28 and other cells. And this way it is a T-cell mediated super antigen problem, and that's why your IVIG is playing a major role. And lung get cleared up early by when T cells are activated, and this virus probably in the abdomen, in the intestine, it gets there, and that's why abdominal symptoms are major. So later on, you may find in adults who are presenting with multi-organ dysfunction, not limited to the lung, there may be a role of IVIG or special you can say and IgG, which is specific to your S1 protein. So this way the research is going, and the way they are also learning from pediatric the role of IVIG in managing these patients. So over the time, I think nothing can be said that these drugs has to be limited only for the pediatric use. And as everybody is agreeing that every week, every month, things are changing. So
thank you, Dhiren. Julfi, you want to comment, or should I go ahead?
I just wanted to say we should absolutely keep an open mind, and we should look at the evidence as it comes and look at the quality of the evidence, because as I believe somebody said earlier on, I think Russell also pointed out, there are good studies. There are also awful studies in COVID, and it, because everything is open access, it's sometimes very difficult to parse these through. There are also preprints that have not been published now for 5 months, and you can well imagine if nothing's been published for 5 months, having been put out in the preprint space, then there is obviously a quality issue. So I'd urge us to keep the dialogue open. For MISC, it's a disorder that I got very interested in very early on because of this very reason, that we were going to get into this issue of whether it's COVID specific or SARS-CoV-2 specific or not. So the review that I pointed out will come out in 3 days' time is an effort to bring together some of the best evidence that we have and some of the ideas around pathogenesis. It will not be the final word, but it will be an opportunity for people to comment. So I would request people to get back to me if they have any suggestions or ideas around future areas of research. There are many research collaborators working on this right now.
Thank you, Dr.
Thank you, Dhiren. I will be very happy if you can answer some of the questions posted in the chat box. In meantime, I invite Dr. Mumtaz Lakhani from Pakistan Pediatric Association to switch on your video. And if you have any question for the panel or any issue related to your country, Dr. Mumtaz. I think, yes.
Okay, hello. Hello.
Yes, please
okay,
go ahead. We can hear
okay.
you. We can hear you.
Bismillahirrahmanirrahim, and good morning, good afternoon, and good night, wherever you are. First of all, thank you very much for inviting us. Dr. Gohar probably could not join because his mother passed away just a couple of days ago. So I'm representing him also. I think that this collaboration is very, very, very important. You know, I have worked for 20 years in USA and now 20 years in Pakistan. And I can see the huge difference. So I think collaboration between South Asian countries is very important because we have almost the similar problems. And I just want you to know that we have developed guideline along with UNICEF, and we are in the process of training right now. So what we are doing is we made 5 modules and we are training the pediatricians who are going to take it further. So I think that at this point, this is also very, very important. And I think most of the questions that you people raised were raised yesterday in our workshop. And the answers are not very different. So like Dr. Bhutta said, we all don't know everything about this disease, but learning, continuously learning and relearning and unlearning is going to be very, very important. So the last discussion that was on ICU care, I think that should be a separate guidelines for care in ICU, because most of the time we are just talking about multi-inflammatory disease, and we are talking about PPE, and we are talking about how to save yourself in primary care. But people who are working in ICU, they also need a lot of help. I had sent Pakistan's data. In the beginning, government was only announcing 0 to 19 and over. And we requested the government that we need to collect the data on children. So I think I had sent some figures. So we have about 9,000 children who have been affected, and very few deaths, thank God, you know. And like Dr. Bhutta said, Lahore has already published multi-inflammatory disease case reports, and they are working on it very much. So at this point, I would like to, wish you all good from Pakistan Pediatric Association. And I hope that, because I have been General Secretary for 1.5 years, and this is the first time that I was approached by SAPA. So at that point, I don't know if the SAPA was not very active, or maybe I was a newcomer, so I didn't know about it. But this SAPA collaboration is welcomed, and I'm very happy that I was just informed a day before. I made sure that I attend this meeting. So,
thank you so much. I am Dr. Bakul Parekh, Secretary of SAPA, and your request for guidelines, the management in intensive care, IAP has come out with those guidelines, and I have your email address, so I will forward it to you.
Thank you very much. Thank you very much.
Bakul bhai, you can go ahead with Bangladesh and Nepal.
Yeah, so now we request Dr. Krishna Bista, the president of Nepal Pediatric Association, a very active member. And Dr. Krishna, if you have any queries regarding COVID-19 in your country, you can ask our experts here on the panel.
Thank you, Dr. Bakul. So good morning, good evening, and good afternoon, everybody. So I am glad to present our data. I think I have sent our data yesterday. We have total now in country 25,000 infected infected persons. Among them, around 15% are children. Among children, mostly are from 15 to 17 years. It may be due to, it's a difficult to say, because mostly less than 10 is around 5%, and 15 to 17 years age is around 8%. And we have few mortality. We have 4 mortality in children. So in total, we have around 95 mortality in our country. So I have, my one question is, we don't have, still around 4,000 children are infected. We do not have separate pediatric hospital for COVID patients. So our patients are treated with adult designated hospital with help of pediatrics. I think, is it necessary to have a pediatric designated hospitals? Because our most cases are asymptomatic still. So when they are admitted, mostly they need only routine care. Very few patient needs, one or two need ventilation, others are not needed. So what's your opinion? Do we need separate pediatric COVID designated hospital?
I think all the panelists will agree that because of low incidence of serious disease in pediatric, a separate pediatric COVID hospital is not viable. And maybe they can be managed in a COVID hospital which is managing adults. I suppose if there is any difference of opinion from Dr. Zulfi or Leila or Dhiren, you can add something.
No, sir, I agree.
Yeah. Okay. So, Dr. Krishna, your question is answered.
Yeah.
Anything else you want to ask?
I think another question always we are facing is open to school or not. I think we have got these answers already. I think in our perspective, it's very difficult to open school because we cannot manage a lot of things which was told earlier.
Recent reopening of school in USA has shown that how the incidents have increased.
Yeah.
So I think that gives us a lesson that we cannot open the school immediately. We have to keep our mind open, look at the progress, and then take a call. So thank you very much, Dr. Krishna.
Thank you.
Now, Dr. Mohammed.
Yeah, I mean, I think on schools, I would like to hear from Russell also. It's very important that we reopen schools, so we can't keep them closed indefinitely, particularly for younger classes where there is no substitute. I think the way forward is to find a pragmatic way of opening schools, just like we're opening industry, just like we're opening other things. We just have to put the standard operative procedures in place. I feel very strongly that until we ask governments and local bodies to make the schools safe by providing things that we need, such as PPEs for teachers, to children, and hand sanitizers, that will never happen. So my concern is that we already have had 6 months that children have not had schooling, and although you may hear all about this tele-education, the poorest of the poor have no access to the internet. They have no access to online classes, and for many critical time windows, you cannot bring that time back. One of the lessons we learned from Ebola was that with the suspension of classes for 6 months, some of that effect was permanent. I mean, the children have never been able to catch up on this. So I think there are risk-benefit analyses both ways. And collectively as pediatricians, we need to help the education people and public health people move forward with a solution that works.
And probably I agree with Dr. Zulfi because more of screen time also is not advisable, and lots of mental health problems also because children are not taking active part in the schooling. So thank you very much, Dr. Zulfi, for your suggestions. And now over to Dr. Mohammad Zaid Hussain from Bangladesh, the Secretary of Bangladesh Pediatric Association.
Yeah. In Bangladesh, so far, we have 33 children have already died. We are managing children actively. It's a difficult situation in Bangladesh because pediatric ICU is lacking, and also so to treat children is sometimes difficult. Only the big hospital have the pediatric intensive care, and we have to treat the children. In my hospital, we have some cabin allocated for the children who become infected with COVID infection. So just from the experience with the adult, we are treating the children in the same way from the experience with the adult, and we are treating in the same way like the adult and treat which are applicable for the children. But in Bangladesh also, the significant number of children have been infected. Already 33 children have died, and 3 pediatricians of Bangladesh have already died, and many pediatricians who have already been infected while giving treatment to the children infected with COVID and while doing practices in their daily life. Almost near about 100 doctors have already died, who are not only pediatrician, but doctors of other facilities also died. So it's what has been discussed. So the school is already closed in Bangladesh. So everybody is in a panic. Even the medical colleges are closed, universities are closed. Everybody thinking about how to take the MBBS exam, how to take the post-graduation exam. That's everybody's has been headache. How to bring school, college, even the elementary school, primary school, secondary school, and also the post-graduate school. How to bring them to normalcy is a big challenge for the whole world, and we are sharing all of the experience with you. And your deliberation definitely would help us to great extent to treat our children and to take the policy to bring our educational institute as well as our the treatment facilities to adopt so that we can treat the children efficiently and effectively. I thanks everybody, Dr. Dhiren Gupta, Dr. Bokul Parekh, and Dr. Zulfikar Gupta, Dr. Laila Namajoba from Russia, Krista, everybody for arranging such a international webinar for the Pediatric Association related to IPA, also SAPA and other pediatric associations are also taking part in this webinar. I think all of us who are sharing our experiences and treatment will be benefited with such a webinar, and we can hold such type of webinar off and on so that we can become abreast of the changes that COVID-19 infection is rapidly changing the situation. So we can update our knowledge and we can treat our children accordingly. Thank you.
Thank you, Dr. Mohammad Zaid Hussain. I think last question, if I'm allowed, Dr. Naveen, to Dr. Leila about the Russian vaccine, which has been launched a few days back. What is your opinion about that vaccine? Will it be very useful? Very available in the market, in the industry? Kindly share your experience.
Thanks for this question. There are a few vaccines for the moment in Russia. Two of them passed the first and second phase of clinical trials, and together with the third phase, they started the process of registration, which was announced in mass media. Reports about the efficacy and safety are quite good, but honestly speaking, there is not so big number of participants of the phase first and two. So we are waiting for the first three with bigger amount of participants. But everybody is asking why we have the early vaccines. I'd like to explain the situation. It's due to the very continued work of this institution of microbiology and virology named Gamaleya. They started almost 2 decades ago, in the beginning of 2000, when the first coronavirus was, the cause of first SARS. So, and this is the result of this very long way. So we are waiting, of course, some detail, because for the moment file is closed, but we are waiting some details to present to our colleagues, and we are waiting also this vaccine this autumn. In the same time, I know that there is some clinical trials of phase 3 of few international vaccines from Pfizer, Merck, and other producers. So I think that in the near future, we will have this chance to compare the result, including antibody response from these different type of vaccines.
Thank you, Dr. Leila. We are very hopeful and optimistic about getting the vaccines, at least by the year end, so that we can be safe. Thank you very much for the knowledge given to us. Now over to Dr. Naveen Thakur, sir.
Thank you, Dr. Julfi. Do you have any comment on vaccine? Everybody is asking when the vaccine will be available.
Well, so there will be a vaccine. I don't think it'll be available within the next few months. So in 2021, we hope to have some vaccines. The big challenge that we face as a global community is access. So as you know, there are already pre-purchased millions of doses of vaccine, and they will be not necessarily available to all the population of the world, particularly in low and middle income countries. So what we have to come up with in advance of the vaccines becoming available is criteria for using some of the Gavi support for those vaccines to have the vaccines administered to people at greatest need. So there should be a hierarchy of things like healthcare professionals, people who are exposed, and then the poorest of the poor who are at greatest risk. So I think the first people to get the vaccine would be those who are at highest risk of adverse outcomes, the elderly people, those who are immune compromised, those who have comorbidities, healthcare workers. So that work needs to start in countries now. So what I'm slightly concerned about is that everybody is only focused on availability at this stage without what's going to happen after availability. So, you know, all of those discussions around equitable access, around criteria, standard operating procedures, how are those going to be given and to whom, and who takes that decision at a local level, that is very much a decision which is a national decision, a national dialogue. So I would strongly urge that South Asian Pediatric Association, SAPA, should perhaps broker some of that initiation of discussion insofar as pediatrics and pediatricians are concerned. But similarly, governments need to take that on as a priority exercise now, well ahead of the vaccine actually becoming available.
So, Julfi, one more question, you know, which is I'm hearing you since a few months, and I heard said around 2 months back when you said that it may take 2 to 3 years for this pandemic to be over. But recently, it was very pleasant surprise to, if I understood correctly, that you say that it may die out maybe, you know, near future. So what are your thoughts about the...
No, I never said it will die out in the near future. I actually said the opposite. Okay. I have said that we will learn to live with this, that, you know, the likelihood of this virus disappearing is very small, that we'll learn to live with it. I think the pandemic control, I agree with Bill Gates. High income countries may be able to control this in terms of balancing out within 2021. But the way we are seeing now, not a second wave, but upsurge. So people have, I just spoke this morning to a large body of people on what has been the Islamic country response to COVID. And it's very clear in some countries, they managed to do well, brought it down, then it went up again. And so they're dealing with all of those fluctuations, and they will learn how to live with this. So I think, Naveen, we should, as pediatricians, learn how to make this very much part of what we do on a regular basis. So just like we learned how to deal with XDR typhoid, you know, with everything else that we did, COVID infections are things that we also need to be aware of. This has been actually leading us by the nose the last 6 months. We've been thinking of nothing else but this. But remember, there are children dying of pneumonia today from respiratory disorders. If you have a child, the children dying of pneumonia as we speak. There are children dying of neonatal problems as we speak. There are children with chronic illnesses. Those things are very much what we need to be bringing back into the remit of holistic healthcare for children, adolescents, school-age children, of which COVID is also a part. Now, it just happens that at this stage, all the resources and efforts in countries are diverted towards some or the other beating this thing down and keeping it under control. We can bring that down. We will be able to keep it under control, but we'll have to learn to live with it and not necessarily imagine that it will just wake up one morning and say there is no more COVID in the world. That will not happen.
Thank you, and thank you so much. So for our audience, we have received so many questions, and we can assure you that we will get answer for all these questions and share with all of you through IPA website, IAP website. Recording of this webinar will be available. The resources, whatever has been discussed, will be available. And definitely we can continue this, as Dr. Eldon said, we can continue this dialogue. I now request Bakul Bhai, with your kind permission, to invite Dr. Basavaraj to give the closing remark. Or you want to say anything, Bakul Bhai?
I think what Dr. Zulfi said is we have to accept living with COVID-19. We have to establish our new norms, to change our lifestyle to live with it. And this, with these few words, I am sure we should invite Dr. Basavaraj, our dynamic secretary of IAP, always active, always helpful, always cooperative, to say a few words of thanks.
Just before Dr. Basavaraj, I can see Dr. Eldon is back on the screen. Dr. Eldon, you want to say anything?
No, I just very much appreciate this. It's been just absolutely wonderful, and I'm hoping we can do this with other regions in the world. But thank you so much. This has been outstanding, and I particular appreciation to the Indian Academy of Pediatrics. You've really done a wonderful job, so thank you.
Yeah, thank you, Errol.
Yeah, over to Dr. Basavaraj.
So thank you so much, Dr. Naveen Thakkar sir and Dr. Bakul Parikh sir. Indeed, it is an excellent discussion involving in a stalwarts. Sir,
I think he has an internet issue, looks like. Dr. Basavaraj, are you having an internet issue? I think he is offline. So let me thank on behalf of IAP. I thank Dr. Errol Eldon from IPA, Dr. Naveen Thakkar from IPA, and my esteemed panelists, Dr. Zulfi Bhutto, Dr. Leila, Dr. Russell, Dr. Naveen Thakkar, and of course my SAPA friends, Dr. Mumtaz, Dr. Mohammad Zaid Hussain, Dr. Krishna Bista, and of course our founder president of SAPA, Dr. C.P. Bansal, and Dr. Professor Ruhul Amin. Thank you very much for being with us on this platform. We really enjoyed interactions with you, and I'm sure these deliberations will add to our wisdom in our practice, in day-to-day practice. Thank you very much, and over to Dr. Naveen Thakkar.
Thank you so much. Yeah, Dr. Basavaraj is back.
Dr. Basar, are you there?
yes. Thank you so much, Dr. Naveen sir. Indeed, it is an excellent discussion with an evaluation.
Okay, I think we have lost you again.
I think let it be Dr. Basavaraj, let Dr. Naveen Thakkar complete the formalities. Yeah.
Yeah. Okay. So thank you very much to everybody. And with this, we end this webinar. Thank you so much.
Okay, thank you. Thank you, everybody.
Thank you very much.
Thank you.
Let's
Good luck. Fast.
Thank you.
Okay.